Hello, everyone. Welcome back. My name is John McCarthy. I will be moderating this session on identifying individual level responses, risks, and strategies. I'm on the planning committee and I serve as director for data and surveillance and suicide prevention in the Department of Veterans Affairs Office of Mental Health and Suicide Prevention. And we'll begin with a presentation by Dr. Richard mcKeon from the Substance Abuse and Mental Health Services Administration. This will be followed by a presentation by Dr. John Franklin Sierra from the LA County Department of Mental Health, and then a presentation by Dr. Lisa Brenner from the University of Colorado and the Department of Veterans Affairs. I just want to note that full biographies and CVs of the speakers can be found in today's attendee packet. And now we will turn to Dr. mcKeon. Great.
So I'm going to try to hit on what I think are a couple of key points from my perspective, working in suicide prevention nationally and as well as with crisis services nationally. And here I would say a lot of the discussions today, quite appropriately, have talked about issues around the amount of data, whether there's too much data available, critical privacy issues, and all of this is very legitimate. But I would make the point that we have too little data at the times and places when we need it the most, in terms of critical decision making that is often life and death. So let me go over a couple of areas, for your consideration. And I'll try to divide my comments around suicide risk assessment into a couple of different areas. I think it's relevant both in emergency and crisis situations. I'll talk more about that. It's also of great importance for ongoing clinical care, outpatient care, or other forms of continuing care. And then, of course, a key part of this National Academy of Sciences workshop has focused on social media platforms, digital interventions, and I will try to speak to that as well. So one of the things, particularly when we talk about the emergency and crisis situations, there's a need to do suicide risk assessments in a variety of different settings. That what they have in common is that it is a crisis most likely for the person in those settings. So this includes on the hotlines, where with the advent of 988 in July, by universal availability by July 2022, we're anticipating many more hotline calls. And of course, part of the reason for 988 is to enhance accessibility by having a more memorable number for people. So you'll have what happens on the hotline, what happens on a mobile crisis visit, and there are significant efforts to increase the accessibility of mobile crisis services that SAMHSA and others have been promoting. The crisis stabilization units, and emergency departments. When I ran a psychiatric emergency service, the suicide risk assessment that I would do on the phone was very similar to the suicide risk assessment I would do in a mobile crisis visit, was similar to the suicide risk assessment I would do in the emergency department. The only difference was the place that it took place had implications for one component of the risk assessment, which was the person's current safety. What was needed for the person to be safe in the community who we are talking to on the phone, very different than what's needed in an emergency room. So one of the things about this line of compelling clinical work is that there has been a stunning lack of research and data in the area about and including the question of the short and long-term mortality impact of key interventions. One of the things on the National Suicide Prevention Lifeline that we were most concerned about was what kind of help the people who are answering the call need for decision-making in imminent risk situations. And what we found out when we looked at the research literature was that there was very little. There are basic questions we don't know the answer to. So emergency interventions, sometimes involuntary, done during this period of time, does it decrease suicide risk in the short term? But what is the impact on the long term if people are then discouraged from asking for help in the future? We don't know. We don't have that data. For this reason, SAMHSA supported Dr. Madeline Gould at Columbia University to work on imminent risk. The Lifeline developed imminent risk guidelines, which included emergency interventions as a last resort. Dr. Gould did a great study looking at the impact or what was some of the factors for decision making at the level of the crisis call center. And there we learned that even for callers at imminent risk, about a third of the time we were able to reduce their level of risk to the point where the call taker did not think that any kind of emergency rescue was needed. This, in the second, about a third of those cases, it looks like we can have a voluntary emergency intervention take place. For example, it could be a family member transporting a loved one to the emergency room, and that in about a third of the situations, that what happened was that an involuntary emergency intervention. And one of the key variables in that was the difference was the extent to which the caller collaborated. So these are really important. I'd note the research literature calls into question the empirical validity of short, medium, high risk classifications. And while that is true, the reality is that we need to make these determinations anyway, because lives depend on it, and to not intervene has the same life and death implications as to intervene. So these issues are just going to be heightened by the 988 being implemented and with more people accessing. And there the issue of geolocation becomes important. 988 will not have geolocation. On May 24th of this month, the FCC will be live streaming a forum on geolocation. Geolocation means that would 988 be able to have the same capacity that 911 has to know where someone is? So for example, if a teenager has taken an overdose, won't allow parents to be engaged or whatever, would we know where that young person is in order to be able to send emergency intervention? And we're also working with colleagues in the 911 communities to try to look at, ideally, what kind of suicidal crisis situations should go through 988 versus 911. There's some very innovative work going on there. Let me also mention that when we're talking about outside the crisis care situation, when we're talking about ongoing care, when we look at something like the Zero Suicide Initiative, the Zero Suicide Initiative involves having protocols for those who have been identified as being at elevated risk, and then providing them with evidence-based care, which can then be the focus of treatment. And what places like Centerstone have found, and I think that this is in accord with some of the other research that's been done, is that that the people who have been identified as being at high risk, if you're tracking on mortality, which we urge every healthcare organization to do, to track on suicide-related mortality in their own healthcare system, one of the things that Centerstone has found is that it was not the people on the high-risk pathway where the continuing suicides were taking place. That doesn't mean it was a mistake to put them on the pathway, but rather it were the people that we didn't know who were at higher risk. This allowed Centerstone to apply a quality improvement process to try to reach those who had not previously been identified as at high risk. In the digital space, let me just mention that the Lifeline chat service has a pre-chat survey. This allows us to know at the beginning of the chat, whether somebody has current suicidal ideation, how upset they rate themselves as being, and a study by Madeline Gould at Columbia on the impact of chat has shown that over half of those who contacted the Lifeline's chat service experienced reductions in suicidal ideation based on the chat. Finally, let me just talk about the issue of suicide clusters and hotspots, a very, very important area that really needs to be further developed so that community-oriented suicide prevention can better take place. There's a particular lack of such information in tribal communities where there have been numerous tragic suicide clusters. And so understanding more about the development of such clusters and the relationship of these clusters to pre-existing high-risk characteristics in a community is a key area for future inquiry. With that, I will stop and grateful for the opportunity to share some thoughts.